Hi, I'm Dr. Randy Martin. We're here at the 2023 AATS Mitral Conclave. As I've said before, you can obviously hear it right behind us. But I'm thrilled to be joined by two colleagues, Rebecca Hahn, who's the world's expert in interventional echo and everything else, Gilbert Tang, cardiac surgeon who's bidirectional, your cardiac surgery and interventional procedures. You know, obviously, imaging has been my life. Echo has been my life, and I remember the early days of moving without TE, being in the OR with a sterile sleeve and all that stuff. But the advances in imaging, it's absolutely critical now to any structural or valve program, and you both have been pioneers in that. Becky, you can't have a program today without excellent, proper imaging.
That's 100% true. I think that, when Marty Leon first coined the term for my position as an interventional imager, an interventional echocardiographer, it really opened up a whole new field. This is a brand new field for us, but in it means that we are part of the heart team for structural heart disease. We see the patients and make the diagnosis. Without making the diagnosis, as you know, Randy, right? It's just, you're never going to bring the patients forward. We've already seen slide after slide after slide of the under-treatment, under-diagnosis of these patients. And so you really need excellence in imaging from the start. So it's the diagnostic phase, and then all the decision-making is in pre-procedural planning. And for that, we have tried to develop guidelines for pre-procedural imaging in order for the interventionalists and imagers and heart failure physicians and everyone on the heart team, the surgeons, et cetera, to make a decision about what's best: surgery, transcatheter, medical therapy, and then move forward. And it's really hinging a lot on the imaging.
So, yeah, and it's as you said, it's diagnosis. And that's often, I've been a big proponent of trying to get to patients where they are with early echoes. And you don't need complex things. You can go up the echelon of what you need. But then when you get into the pre-procedural and intra-procedural, then the imaging becomes critical, and obviously following them. Gilbert, what are your thoughts? Because you're intimately involved with CT, simulation, picking up all the stuff, but also with echo. Tell me your thoughts.
Yeah, I think it's a combination of what we call now multi-modality imaging. And that involves not just echo, but correlating echo findings with CT and kind of interrelate each other so that you can actually plan procedure. And Becky will tell you, 90% of the structural heart procedure is planning.
Correct.
The execution is also important, but once you have the plan, then you make sure the procedure can be done safely and efficiently. I think that also maximizes the patient's comfort and also safety.
And Becky, I'm sure you found this, but I did in the early days in the OR, is that when the surgeons, this is cardiac ORs, the surgeons know that you know what you're talking about, then pretty soon, even if they don't know it, they'll ask you, what do you think? How's it look? And all that. The same thing now with more complex interventional procedures, which you're doing. The tricuspid's a great example.
Yeah.
Is that right?
It's absolutely true. But it's not just, what do we think? We're actually doing the guiding. So
that's what I mean.
Exactly. So the
this way or go
exactly. So because we have all these advanced tools, and so many of the new tools, Randy, have been really developed for the interventional imager. So live multiplanar reconstruction, we can't live without it anymore.
Right.
Or just being able to rotate the orthogonal plane, the secondary plane, to any angle that we want in order to optimize the clip arms.
Right.
It's just, these were all developed, I feel like they were developed for the interventional sphere.
I'm going to come back because the CT stuff, you and I were in a session this morning. You did some excellent stuff on the scope of CT. Becky, it needs excellence, though, and this isn't for somebody just to run down from the echo lab and do this. There's got to be specific training and procedural guidance, doesn't there?
100%. And that's why the ASC just came out with their advanced training statement for interventional echocardiographers, because it does require advanced training. And it started with the ACC advanced echo training statement by Dr. Wiggers, and then it's just moved on from there. And so it's fairly prescriptive about what the minimum requirements might be as far as volume, which obviously doesn't necessarily ensure competence, but at least it's an attempt to make sure that enough of the pathology is seen. And then the American College of Cardiology is also seen, as Gilbert has mentioned, about multi-modality imaging. And so we're now developing an advanced training statement for multi-modality imagers, because that's...
You say multi-modality, you're talking about CT?
CT, CMR, nuclear, and echo.
Oh, really?
Yes.
That's interesting.
Because there's also diagnostic component, as Becky mentioned, right? And some of them require those, expertise, obviously from a procedural planning standpoint, it's still mostly echo and CT, but there are other diagnostic components that we need to look at as well.
So if somebody who's interested in this wants to get degrees or get certificates in multimodality, are we talking basically intensive echo, interventional echo, and CT? Or are they going to, because you mentioned 5 modalities.
Yeah,
Sorry for people to, they say, I want to be through in 5 years.
Yeah, it's pretty clear that you're not going to be an expert in all of the modalities, and that typically people will choose two, depending on where their focus is. If your focus is the guiding of the procedures, then CT and echo are going to be absolutely key. But then there are those that want to do CT CMR or have an interest in more diagnosis, which might be nuclear or PET scanning. So it depends on your focus, but nowadays it's really going to be more than one modality. So you and I are going to be dinosaurs. We trained in one modality, but even now with the heart team, we're able to see the CTs on every valve case, and we'll review and make sure that it correlates with the echo.
Gilbert, your talk this morning was excellent. I'm obviously more familiar with echo. Obviously, I'm familiar with CT, but where is CT in diagnosis and procedural planning?
I think CT has come a long way in terms of, in terms of being reproducible. I think that's one of the most important things, and then the measurements are actually reliable. I think the biggest question mark is the modeling aspect of it, of these newer devices. Can you predict the rotation element or the canting or the deformation of this deep? This is right now still a biggest question mark in terms of predicting the final outcome. Obviously we want it to be better than expected,
right,
but unfortunately sometimes there's still, adverse events that happen because we couldn't predict it. So I think that is the biggest question. And I'm now hoping that, through working with Becky and others, to look at echo as a correlate. Can we, using both, so when you do it during the procedure, and we talk about, even some advanced fusion possibility, that we can actually predict this with a higher degree of certainty that an adverse event, and particularly for mitral side, in terms of replacement, like LVOT obstruction or parabaric leak or some kind of migration that might not have been expected, can be minimized as much as possible.
Is it a role for CT? And obviously I'm thinking of simulation and all the things you mentioned, but for coronary anatomy and relationships and all of those sort of things too? I mean, it plays it, so,
yeah, they're
you don't want to get too close to the front.
Yeah, there's software now that's doing that, but I actually, because echo is so prevalent and so easy to do, because everyone starts with transthoracic echo, right? I mean, to diagnose and then go to TEE. My dream would be actually use echo to model some of the elements that you can perhaps superimpose, almost like fusion, to be able to model something, because it's dynamic. Remember, CT, even in multi-phase, is still somewhat static, and it's still not really truly physiologic, because echo really depends on the loading condition and some of the elements. That would be, I think, a holy grail, and I think some of the things that you've done, such as artificial intelligence, getting all the data, will be able to get a better predictability.
It's pretty easy to do that. I mean, you can see, obviously, with echo, the relationship of the circumflex and the right coronary artery to valvular structures and all that. Becky, has the American Society of Echo, it's come out with guidelines, okay? Are we at the stage where you really have to have certification or credentials to be an interventional echo person?
That's such a great question. I mean, I think that without the guidelines first for recommendations of training, it's hard to then go to the next step of certification and board certification. And so we had to start with the guidelines and to really get the buy-in of all of the stakeholders that this is actually a new field, that this requires extra training and now likely should require certification in order to ensure competence. And so I think we're doing it step by step, and that's the first step is to develop these advanced training statements and hope to then certify.
Gilbert, the surgeons are familiar with echo. Obviously, you'd like them to be more familiar, but remember back in the early days, Bob Guyton at Emory had his cardiac surgical resident spend 6 weeks with me. We taught him echo, transthoracic NTE, and stuff, which I think is important. But do the surgical interventionalist or the interventionalist now, a lot of the interventionalists are cardiologists, so they have some training in echo, but are they much more knowledgeable now about what the technology can do and how to interact with you all?
Well, I would say learning echo is different from knowing echo and working with the interventional echo imager. Because number one, there's new vocabularies to learn. The new anatomy and atomic landmarks, you're kind of merging what we learn as a surgeons into some of the anatomy to now correlate it with echo. And I think it's important for any structural interventionalists and operators to work with echo imager to kind of learn that, and so they're all on the same page. So for example, I believe in a co-pilot model. Procedures are echo-driven, right? Echo-guided, but the interventional operator need to know what's going on the imaging side, and also the imager also need to know what device as well, so that they can actually talk in synchrony. I think that is something that is lacking right now in the field, and Becky and I have been trying to work on training people in that regard.
Yeah, I think the communication aspect is absolutely critical in the procedural rooms, right? And so it is really developing that special language between you and your interventionalist, or the interventionalist and the imager, so that your communication is seamless and is clear, and then you can accurately position valves. And so, I think it becomes part of the heart team mentality, just really accepting the fact that
and the operators need to learn that. I think they need to be humble and be able to willing to communicate in the same language, because you don't want an adverse event, and you don't want and you have to be patient. I think patient has not been surgeon's virtue, as we know, but sometimes you just have to be patient and let the imager guide you and show you what you need to go. It's like driving a car, right? If you can't see the windshield, you're not going to be driving forward.
I understand that you kept them from having a wreck.
Exactly.
Both of you have been pioneers in this, and I think it's really, really important, because this is a specialized field.
Yes.
And it does take a specialized language and colleagues that trust each other and know. So you both have been pioneers. So thanks. You. And we'll look forward for continued advances. So thank you for joining me.
Thanks.
Thank you. Thank you. This is very important. So learn about imaging. It's critical to your program. Thanks.